So we're still talking about the nutritional support in our patient, and now we'll talk about the access routes for nutrition. These include the enteral or the parenteral route. Then we'll talk about the total parenteral nutrition, the related concentrations and complications, and finally the composition of total parenteral nutrition. So, this table compares the advantages and disadvantages of enteral and the parenteral nutritional routes. We've talked about it before. The enteral route is the preferred route of administration of food. However, parenteral route is equally used because in certain patients you cannot use the gastrointestinal tract, and the parenteral route is the only way for to give nutrition to the patient. Let's get into the advantages of enteral route and see what they are. So advantages include the enteral route is physiological, that is the that is from where the food is supposed to go and to be absorbed. It is simpler because the mucosa has developed itself to absorb food, and that is what the function of that mucosa is. It's cheaper because there are no specific preparations are required. The food has to be given simply, and it is absorbed there. Now it has less monitoring. We see then not a lot of monitoring is required, and it is less complicated. On the other hand, with parenteral nutrition, the only advantage is it's independent of the GI function, and that is it enters into the bloodstream directly. So it is independent of the GI function. Now, the disadvantages of the enteral nutrition, these include it is dependent on the GI function. That is, if the GI function is not normal, the absorption of food would be decreased. It can lead to diarrhea because this food contains a lot of osmotically active agents. If not absorbed, these osmotically active agents can produce diarrhea. There can be feed intolerance. Whatever you're feeding to your patient, the patient might develop an intolerance towards it. The NG tube, the nasogastric tube, the tube that goes through your nose into your gastric canal, finally into the stomach. It can be in the wrong position. That is, there can be malposition. It can lead to sinusitis, that is infection of the sinuses, and there can be pulmonary aspiration. So if the food is aspirated, it can go into the tracheobronchial tree. Now, with parenteral nutrition, the disadvantages include it's non-physiological. That is, the buffers, the support mechanism, the help that is present in the GI tract is not present in the blood. So it is a non-physiological way. It requires venous access. So you need to access a vein so that you can give the parenteral nutrition. So it has you have to violate the bodily rights of a patient, not the rights exactly. You have to enter into the veins of a patient to do that. There's higher risk of systemic infection because you're already in the vein, you're directly into the bloodstream, so an infection can progress directly into the bloodstream. This is expensive because it requires monitoring. The food that is given is specialized. It requires catheters, so it is expensive and it is more complicated, obviously. So this gives you an idea of the difference between the enteral and the parenteral feeding. Again, enteral is the physiological and the preferred method of feeding, but the parenteral method is used equally for certain patients who cannot tolerate enteral feeding. So what are the considerations with the total parenteral nutrition? So the total parenteral nutrition must be delivered centrally to minimize the risk of venous sclerosis. So central veins, they have a bigger lumen, so always a central vein must be used so that the tightening or the stenosis of the vein does not take place. Now, the patient on TPN, that is total parenteral nutrition, should be monitored regularly. And how does this monitoring proceed? By monitoring the blood sugar level, by monitoring the serum electrolytes, and by monitoring the liver function cells. All these parameters need to stay within the normal limits, because you are feeding directly into the bloodstream, and any alterations in either the blood sugar, the electrolytes, or the liver function can have disastrous effects. So, what are the complications of total parenteral nutrition? The complications of total parenteral nutrition can be divided into access related and metabolic. We'll go into the detail of the access related and metabolic complications, and we'll see what these are. So first of all, we can have pneumothorax. So while getting access into the vein, you actually punctured the lung, the thorax cavity. So now air accumulates between the pleural leaflets, and it causes the puncture, from the puncture or the laceration. So you can have pneumothorax. Then you can have carotid or subclavian arterial injury. Again, you were trying to access the carotid vein, the subclavian vein, and you accidentally injured the artery. So there is accidental puncture of the adjacent arterial structure. Then they can be catheter malposition and arrhythmias. Now the tip of catheter, which is being used to administer the TPN, may find its way into an unintended venous structure or the right atrium itself, and the position of catheter at that sensitive point may lead to arrhythmias in the heart. Now, there can also be venous thrombosis, and there's thrombus formation in the major vein due to alteration of the blood flow and presence of the foreign body. So the catheter that is present in the vein, it may cause disruption of the blood flow, which might produce a thrombus around the foreign object. These were the access related complications. Now let's talk about the metabolic complications of the total parenteral nutrition. So first of all, we have hyperglycemia. Hyperglycemia may occur due to excess carbohydrate administration, obviously, or due to glucose intolerance, or due to combination of two. This is the most common complication seen with total parenteral nutrition. The patients usually have an altered metabolism, and as a result of which the patients either do not respond to carbohydrates, either producing less insulin, or the insulin insensitive, or frankly diabetic. So whatever the case may be, hyperglycemia can occur in these patients. Now they can also undergo hypoglycemia, and this can occur due to sudden cessation of the total parenteral nutrition. You must understand these patients are not getting anything from the enteral tract itself. So since there's no support from the enteral tract, withdrawing total parenteral nutrition may lead to hypoglycemia. This withdrawal, while the insulin stimulation has not yet subsided, would be disastrous for these patients. Now they can have carbon dioxide retention. So how can that be? There's excessive carbohydrates. These excessive carbohydrates produce a lot of, they're utilized to produce energy, and they produce carbon dioxide as a byproduct, and this is retained, and this leads to excessive carbon dioxide production. Then we can have azotemia, which there's excessive protein administration with inadequate calories. So the adequate calories are not given to the patient. As a result, there's excessive protein breakdown, and this is the azotemia. Then we can have essential fatty acid deficiency. So talking about essential fatty acid deficiency, there's inadequate essential fatty acid administration. Again, keep in mind there's no enteral support. So this is the only route of administration of food to these patients. We can have hypertriglyceridemia. In hypertriglyceridemia, there is rapid fat infusion or decreased fat clearance. Moving on, we can have hypophosphatemia and hypokalemia. This is sudden full strength nutritional restitution in a starved patient. So this is what the refeeding syndrome is. In a refeeding syndrome, you can have hypophosphatemia and hypokalemia. And why is that? Due to sudden overfeeding of a starved individual. Now, there can be any electrolyte abnormality, the access, or there might be either an excess or inadequate supply of that electrolyte in the parenteral nutrition. Then we can have hemorrhagic diathesis due to vitamin K deficiency. Then there are infectious complications where various infections can occur. Septicemia can occur because the catheter tip might become colonized with bacteria and acts as a continuous seeding source to the bloodstream. Then at the site of the skin where the cannula is, we can have skin site cellulitis. The skin flora enters the subdermal or the subcutaneous space. Now finally, we can also have pneumonia or other systemic infections because the high N6 fatty acid, their content, that adversely affects the immune function. That causes production of pro-inflammatory cytokines, which can lead to pneumonia and other systemic infections. So this is a list of various complications of the total parenteral nutrition. With this, you can see it is not the preferred method, but since it is required that frequently, you must know the complications of total parenteral nutrition. So what is the composition of a standard formula of a total parenteral nutrition? Mind you, the formulas are designed according to the needs of the patient, but what does a standard formula contain? So in terms of volume, it has 10% amino acids, that is the protein component, 50% dextrose solution. Now 50% dextrose solution is the carbohydrate component. Both of these are 500 ml. Now there's fat emulsion in there. Then we have electrolytes, vitamins and minerals up to 50 ml. Now the total volume is 1050 ml, 50 ml more than a liter. Now the composition in grams, this includes the amino acids, which are 50 gram, dextrose, which is 250 gram, total nitrogen is about 8 gram. Now dextrose, the calories, the kilocalories of the energy by dextrose is 840 kilocalories, that is about 2000. Now electrolytes which are present in the total parenteral solution, these are the sodium, the potassium, acetate, chloride, phosphate, calcium and magnesium. The amount or the amount of these electrolytes, the amount of these solutions that are present in the total parenteral nutrition, they actually need to be adjusted according to the requirement of the patient. All patients have different dietary requirements. All patients have different statuses of nutrition, and this formulation of the TPN should be adjusted according to the requirement and the suitability of nutrition to your patient. So this was all about this section. In this section, we talked about the routes of administration of nutrition to a patient. Then we talked about the complications of TPN, and finally we talked about the complications, and finally we saw what is the composition of TPN. I hope you liked and understood this lecture. For further such lectures, keep watching sqadia.com.